During this past year, I have had an opportunity to have my own education of the leadership of our valley. Uh, Typically, I've just been in the hospital or the laboratory, the exam room, and never really got the chance to meet so many people and understand how much of an effort goes on to maintain this wonderful place that we live. So I owe all of you a great deal of thanks for all of the work that you do. And in my mind, it's almost all behind the scenes. So I've learned a lot this year. I'm going to try to share the screen, and let's see what comes up is what we want to come up. Uh, Many of you have seen some of these slides, and I'm going to give a quick overview of coronavirus and then try to emphasize where we are today, what we have learned, and then since this is a leadership comment or conference, maybe some comments about some of the things we've learned about leadership and how some of the mistakes we've made. So the big picture is here. This is the big picture. This is the dueling locomotives, new cases versus vaccination. And when I first showed this slide, the vaccination train was way behind and new cases were surging, and it was a huge problem. Now what we can see is the vaccination is neck and neck with new cases. We still are having new persons getting infected. We still are having hospitalizations and unfortunate consequences, but far fewer than ever before because of the number of people who have been vaccinated. So this is really an exciting time for all of us. So just highlights of what we've seen over the past year, not to emphasize the dates, but maybe to refresh our memory. It was New Year's Eve when China announced an outbreak by a new virus. They clearly had been treating people, but it wasn't recognized as being a cluster of infections until New Year's Eve, and then they announced it worldwide. We saw our first US case in the United States, which I believe was the state of Washington, of an individual who had traveled to China on January 21st. February was when I saw my first patient with COVID. And that's when the Diamond Princess, quarantined off of Japan, started to transport American citizens from the ship to the United States. And they came into Travis Air Force Base. Those who had symptoms or those who were thought to be sick were spread out through various hospitals in Northern California. Both John Muir and San Ramon Regional received patients, and that's where I saw the first patients of the pandemic. A major event for all of us was in March when the county health officers of all 7 Bay Area counties issued a stay-at-home order, and that was huge for all of us. And we all thought, and myself included, this is going to be temporary. You know, we can do it, but by June, July, certainly by August, this will be over because, I mean, after all, this is the United States. And one of the things we've learned is you always have to plan for the unknown. And what a surprise it was to all of us. Then face coverings came into play, the importance of understanding how masks can prevent spread as well as protect a person. And then by July, the vaccine trials began. Now just look at this. This is the first US case in January, and we're starting vaccine trials in July. This was because of a massive effort, a funded effort by our government to facilitate vaccine development. And all that was done was go back to your companies and develop a vaccine by the way you usually do. So this went out to all of the vaccine manufacturers and also went to the NIH. So the NIH does not take credit for a lot of things, but the NIH is the brains behind the Moderna vaccine, and Pfizer itself is the brains behind the Pfizer vaccine. They happen to pick the same platform, which looks so far like it is going to be the Rolls-Royce of vaccines, not just for coronavirus, but perhaps for many, many other diseases to come. And we were really doing well until all of a sudden this term variant came into play. We're going to talk about that a lot more because that's the highlight of what's going on right now. A variant is a stable mutation Viruses mutate all of the time, but if that mutation is stable and it creates a virus that acts differently from the original or the wild type, that is tagged a variant. And we'll talk about what has happened. And there we are in December. Literally 11 months after the first US case, we have vaccines available for US citizens by emergency authorization of the FDA. Now, this is what we have learned. This is a person-to-person respiratory virus. 90% or more of this virus is spread from one person to another as one person exhales, coughs, sings, sneezes. Another person inhales it. That's how this is spread. If one happens to touch something that is wet with mucus from a sneeze or mucus from a cough and then touch their face, yes, that can occur. But that is such a rare consequence. It is what you're seeing there in the upper left. This is the spread of the virus. It's a person-to-person virus. We had all of these publications talking about how long is the virus detectable on surfaces. And I was in this too. In my house, we were, can you touch the grocery bag? And can you touch the box that comes from Amazon? And what about the clothes? Can you touch your neighbor's jacket or hang up their coat without getting infected? And I'll tell you what we have learned. First of all, the quick answer is no, all of that stuff is safe. It's not groceries, it's not food, you don't get it by eating, it's not packages. But these numbers are correct, but the word here is detectable. How long is coronavirus detectable? Not how long does it live? Detectable for a virus is not the same as infectious. Detectable for a bacteria usually is. So if we say, how long is the Staphylococcus detectable? That's almost synonymous with infectious, but not viruses. And that takes us into the testing that we do to explain this phenomenon. There's two kinds of testing that are available today. Antigen testing, where we look for the spikes on the outside of the virus. So antigen testing is looking for a spike or a protein on the outside of the virus. And these tests are valuable because they're quick. These are the rapid tests. These are the ones that are even now becoming available for home use. These are the ones we hope that we can reach a situation where we can line up kids when they come to school and do a 5-minute test and say, you're cleared, go to class. The PCR test is a long, laborious test, and it looks at the inside nucleic acid. So not the outside of the cell, but looks at a piece of the nucleic acid. These are extremely specific. That is, if it's positive, it's positive. The antigen test, on the other hand, is a quick test, but may have false positives. The PCR test is the one that is the best. Now, both of these tests have been used to measure the detectability of viruses on surfaces, on cardboard, on doorknobs, on packages. But the virus can be dead and these tests still be positive. And that's what we have learned over the past year. It's a person-to-person disease, even though we can detect fragments of a virus on surfaces. It's like detecting a fragment of a car, but it certainly doesn't mean that you have an operating vehicle. So these tests are both designed just to test a fragment of a virus. Now, if you can detect a fragment of a virus in a person who is sick, then that is satisfactory to say they have disease. Of course, there's going to be times when that's not true. But by and large, if you can detect a fragment of a virus from a person who has typical symptoms, that's all that's necessary to make a diagnosis. Or if you can detect a fragment from a virus from a person who has no symptoms and it is positive on more than one occasion, that means that they are infectious but have no symptoms. And about a third of the people now in the United States who have had COVID have had no symptoms at all. So that's another big point we've learned. We don't even know if this is true for flu. We don't know if it's true for measles or mumps or rubella. We've never looked at it before because they weren't pandemics. They didn't create the concern that we have of spread because it was controllable. So this may be true of every viral infection. We now know from the COVID experience to look for asymptomatic spreaders of this virus, a big lesson learned in respiratory viruses. Now, here's another phrase that became so common in the United States all through 2020. Let's flatten the curve. Social distancing, wear a mask, wash your hands, don't put your hands to your face. Flatten the curve. The curve is the number of new cases occurring by day or by week in a city, in a county, in the United States. Flatten the curve. And indeed, that is what has happened. You can see where we are at the end for March of 2021. We have pushed down the number of new cases, which of course is a pillar of why reopening is occurring. It's not the only thing that's being looked at, but the number of new cases per day is clearly going down. And we're very, very pleased with that. That doesn't mean that it can't go back up. So there's always caution when we reopen, when we open schools, when we open retail, when we allow indoor dining, we're not going to stop following the number of new cases per day. This infection is not over, but we have a baseline and we can watch it. Now, I want to show you this same graph kind of scrunched together and emphasize a different point. This shows what happens after selected holidays. So pretty easy to see what happened after Thanksgiving. This is Thanksgiving, and this is the post-Thanksgiving spike. Here's Christmas and New Year's and the post-holiday spike. As a matter of fact, this spike right here is after 4th of July. And this was what we were concerned about. There's super spreader is a term. These are super spreader holidays where spreading occurs in a large amount of time suddenly. So this curve right here, although it's difficult to tell the way I presented it, is much steeper than the general upswing that we're seeing here. So Thanksgiving had a major impact. Christmas had a major impact. Labor Day did not. And I'll show you why on the next slide. And 4th of July probably did, but this is still kind of soft to show any change in the slope of the curve. So what's going on here? What have we learned about events that represent a threat to people, to the number of new cases, to the country in general? Well, here are some super spreader events. Cruise ships, definitely, no question, a lot of cases of those who were confined in cruise ships. The protests and the riots that occurred in May and June, well, these were people who were jammed together, who were yelling, who did everything that one should not do for safety. But we're not hearing a lot about the effects of the protests and riots, yet we were very concerned about that. The 4th of July holiday, similarly, people are going to be gathering from neighborhoods. There's going to be parties and barbecues. Very concerning. The Sturgis motorcycle rally is 250,000 people in one town in Sturgis. And I just can't tell you how many conference calls we had about the concern of the Sturgis motorcycle rally. Then most have heard about the Rose Garden event for the announcement of the Justice of the Supreme Court, Judge Connor. And then the Super Bowl was another time. Even though there were very few people in the stadium, I think it was limited to 20% occupancy, Super Bowl events occur all over the city of Tampa. So what have we learned from all of these? Well, this is what we have learned. Those that represent a problem were indoor. So the cruise ships, basically that's all indoor, crowded times, same air circulation on many of the decks, but it was an indoor problem. There's not a lot of outdoors on a cruise ship. Protests and riots, almost all outdoors. Very few problems in any city in the United States that they can link to the protests and riots. When case investigation has been done for those who acquired COVID after 4th of July, it was those that had indoor parties, and those that had outdoor parties did not. The Sturgis motorcycle rally was very interesting because although most of it was outside and there were outdoor parties and barbecues and music concerts, there also were indoor bars open. And those who have traced their COVID to the Sturgis motorcycle rally were those, or all of those, have been inside at a bar or a restaurant while they were there. And the Rose Garden, I'll tell you, the Rose Garden really confused me because every time I saw the news and I saw pictures of the Rose Garden, I saw people sitting outside. And it really threw a monkey wrench into my thinking and many others as to, if we're outside, which is supposed to be the safest environment, how did these people get it? And I didn't find out until much later that before and after the outdoor announcement, there were indoor cocktail parties in the White House. And so the super spreader event that occurred during the Rose Garden likely occurred indoors rather than outdoors. And the Super Bowl for the same reason. So what we've really learned here is that this is a disease which is so much more dangerous indoors than outdoors. And the basis of it is circulation. The air circulation that occurs outdoors dilutes almost everything quickly that is exhaled by a person who may be infectious, who may be contagious. But the air circulation indoors can be very dangerous, particularly in a regular household. So this is, to round it out, this kind of sums it up. The biggest places of concern right now are congregate living, places of worship that are indoors, crowded workplaces like the laboratories where I work, where bench techs are next to each other, indoor funerals, airplanes, prisons, bars, dormitories, all of these places have had super spreader events, but almost none have been traced to a playground, hiking trails, dog parks, other outdoor recreation, or even other outdoor activities, even if it's work. So this is what we've learned about respiratory person-to-person viruses. It's based on air exchanges and air current. And for our purposes, the biggest difference of all of that is indoors versus outdoors. And you'll see some of the new recommendations that have come out about, we'll talk about them later, about vaccinated persons. It's related to what you can do indoors, and that is a big change. So I'm not going to talk too much about the clinical disease. It's pretty well known by everybody because of the vaccine rollout that those of advanced age and as age increases are at greater risk. And that seems to be pretty common knowledge. So I'm not going to address that so much, except to say that the severity of the disease and the risk of hospitalization and the risk of not surviving is clearly associated with age. But let's take a look at what is new. It's now called long COVID. It used to be called long haul COVID. This is becoming a major concern in the United States, both by clinicians as well as public health officials. And this graph just quickly shows that how many people have symptoms for more than 2 months. And you can see that it's up to 60% have fatigue, 40% still have shortness of breath 2 months after recovery. And some other studies have shown that as many as 70% will have ongoing symptoms even past this, and some as long as 6 months. Now, this is why this is becoming so important. These are mostly what is known in medicine as B symptoms. B as in Bravo. In other words, this is what a patient feels, but it's hard to measure. You can't really measure tiredness, and you can't really measure shortness of breath in the absence of documented changes in pulmonary function. You can't measure pain. Very difficult to measure blurred vision if it can't be seen by an ophthalmologist. But these are real. I'm absolutely convinced from the number of patients who have been studied, and we're now up into the thousands of patients who say, look, I'm just not back to normal. And this is why this is a problem. It's because we don't in the United States have a way to help these people if they need disability, if they need unemployment, if they need help at home, if they need home care. There's nothing on this list that is going to qualify for an individual getting health care or financial support. And that's why this is becoming such a big issue. We don't have this with almost any other viral symptom. I can only think of a couple, or syndrome. I can only think of one or two that may have such long-lasting effects in the absence of complications. I'm not talking about something that occurs when you're acutely sick, like a stroke or blindness or a blood clot. That's not what I'm talking about. I'm talking about the persistence of B symptoms. So this is long COVID, and it's going to be more and more prevalent in our news, as well as the attention that we're giving on both a local and national level. Now, I'll tell you just an anecdote. This came out yesterday morning, is that in a very small group of people, and this is not a well-controlled study, it's a very small group of people felt better for the first time after they got the vaccine. I'm not going to attempt to explain it. That's one of the things that I have learned during the past year. If we're talking about lessons learned, one of them is know what you don't know. Well, no one knows why some people feel much better after getting the vaccine. One could theorize it. Currently, the vaccine is generally delayed for up to 90 days after having acute COVID. And that is because it's unlikely for a person to get infected. And so the thinking has been this: look, if you've had COVID, you don't need the vaccine for 3 months. Let someone else have it. That's the thought process, sort of an altruistic thought process. Well, now it's leaning toward the fact that maybe there is a reason to give a vaccine to someone who has had COVID. So very cutting edge stuff, very exciting from the field of medicine. That's where we are today. But stay tuned regarding what's happening to long haul COVID. Okay, variants. This is the hottest thing, variants or mutations. So this is a picture of the outside of a coronavirus. It's called a coronavirus because it has these spikes around the outside, that it's a crown of spikes. And these spikes are what makes this virus infectious. These spikes, where the arrow is right now, is what sticks to a cell in the back of our throat, or the back of our nose, or in our lungs, or in the windpipe. This is the part where the virus attaches to a person. And this spike is coded by a gene in the coronavirus nucleus. So this is the coronavirus outside. This is the inside. These are the spikes cut in half. This is the nucleus of the virus, and here is the gene that makes the spike protein. If there is a mutation in the spike protein that is stable, it will produce a different looking spike. It will produce a spike that may look like this compared to one that looks like this. Now we have a different virus, and it's changed in the area where it attaches to human cells. This is a big deal. So we have a change in how the virus attaches to the human cells. Now, to make this even more important, our vaccines are all directed to the spike. So vaccines make antibodies or try to neutralize the virus, but what they do is they stick to the spike so that the virus cannot attach to humans. So if I have antibodies from a vaccine to this spike, and somebody coughs in my face, and they cough coronavirus in my face, my antibodies will immediately stick to this, and the virus is flushed away. It will not cause an infection. That's how vaccines work. They neutralize the virus before the virus can cause an infection. Well, doggone it, if we change this spike so that the antibodies that I got from my vaccine don't work, then the vaccine doesn't work. So that is the buzzword on variants. Variants are of importance when they affect the spike, when there's a mutation that changes the spike, and the biggest concern is changing the spike so that it does not respond to the vaccine. And that's what we're looking at. Now, in the United States, we never looked for variants. We never looked for genetic mutations of the coronavirus, never thought about looking for it. There were research laboratories and universities that like to do this stuff, but never on a national surveillance level. Just never did it for anything. Didn't do it for flu, didn't do it for measles, didn't do it for rubella, never thought about doing it for coronavirus. But the United Kingdom does. England has been looking at mutations of virus for decades. And they are the first to report, hey guys, guess what? This doggone virus is mutating. And it's mutating in an area that is clinically important. So remember, a variant is a mutation such that the variant acts different from the original strain or acts different from what is called wild type. And England said, we found this B117 variant that is much different clinically. It's all over UK. It's much more infectious. The spike attaches tighter to the humans, and we think we have a problem. And that woke us up in the United States as well as worldwide, that we have got to start looking for this. And that is exactly what is happening now in the United States. We're now collecting viruses and testing about 3,000 or 4,000 viruses from all over the country at one site, looking for mutations, looking for variants that may represent a problem. So this is new to us in the field of virology and certainly in the field of respiratory virus infections. So that's what this is all about. And here's where we are today. These are the known variants as of yesterday. So we see these are the variants, they're numbered. This is where they were identified. And I told you about the B117. This is the one that woke all of us up that came from England. The 1351 from South Africa is a real problem because one of the vaccines, which is soon to be released, just doesn't work at all against this variant. The P1 is from Brazil. One of the problems with it is that it's more infectious than others. And then the other two are the California variants. Because we've been testing now in the California State Lab, we have identified two stable variants. So the 5 that have the arrows beside them are the ones that we are looking at most closely. And the CDC and the World Health Organization now have created a clinical classification of a variant. It's something of interest. Well, we're always of interest. Of concern, that's a real deal. That means there is a reason to suspect that the variant could cause harm to persons, either by being more serious, more infectious, or evading the vaccine. And then there's those variants have been of high consequence. As yet, we don't have any. High consequence means that it has created a new epidemic. It evades all vaccines and changed the shape of the curve. This 1351, if we were in South Africa, we would call this a variant of high consequence. And the reason is South Africa was using the AstraZeneca vaccine, and the AstraZeneca vaccine does not work against this variant. It works great against the 117. It works great against the wild type. But this variant changes the spike where that doggone vaccine is meant to work. And so AstraZeneca has been pulled from all use in South Africa. Now, in the United States, we don't have AstraZeneca vaccine, so it is not yet a variant of high concern. And I'll show you in a couple of slides how we react to 1351 with the vaccines that we now have available. And that lets me segue into the vaccine. As you know, we first came out in the United States with 2 vaccines, and I am so surprised that how many people in cocktail party language say, well, what about this mRNA vaccine? Now, these are things that no one outside of science has ever heard of, and that's RNA or ribonucleic acid. Well, these are remarkable vaccines. These are new. They've never been made before in the United States, never been used in the world for any human disease. That's how new they are. What they do is it's a messenger RNA. That's what the vaccine is. And it goes into your arm, gets into the muscle, and uses the muscle cell to make the vaccine. It uses the muscle cell to make what's necessary to produce antibodies. So instead of giving chopped up coronavirus or chopped up spikes, we're actually giving something to make spikes in our own body. And that's what the messenger RNA vaccine is. It's been a laboratory tool and a laboratory enigma for years, but never before used. And it has proved unbelievably powerful, easy to manipulate, creates very, very high titers of antibodies. It is probably just going to change the world of vaccinology with this new technique. And so this is what the Pfizer and the Moderna vaccines are. They're both messenger RNA vaccines, a little bit different in structure, but same platform, same concept. And now just looking at the vaccines that we have available or are coming down the pike soon, I put 5 here. And there's a lot of information on this slide. I'll take the time just to go through it. On the left, Pfizer, and this is the order in which they were approved by the FDA. Pfizer, Moderna, the Johnson & Johnson or Janssen vaccine, the AstraZeneca, and then one Novavax, which is in the pipeline. This is the remarkable. You know, we don't have very many vaccines in the United States that are 95% effective at preventing disease in all comers. This is not just individuals who responded. This is 95% of the people who took the vaccine. Now, granted, in the trials, we didn't give the vaccine to children, and you didn't give the vaccine to people who are immunosuppressed, and didn't give the vaccine to individuals who were thought to be or planning to become pregnant. So it is a selected population, but history has always measured new products this way in the United States. Nothing has ever shown to be this effective. This is absolutely fantastic. The other thing that we know so much more about Pfizer and Moderna than we do the others, so I'll talk about that for a little bit. The amount of antibodies, the amount of protection is unbelievable. So if I told you that you needed a blood level of 10 to be protected from coronavirus. So the vaccine causes antibodies, and we measure the antibodies, and you get a blood level of 10. That's what you need to be protected. These vaccines produce levels in the thousands. That's how powerful they are. And because they produce levels so high, protection lasts at least a year. And we don't even know how much longer it lasts. Smallpox vaccine, for example, lasts 10 years. Well, we don't have any idea how long these vaccines are going to last because the level is 100 times or close to 200 times more than what is necessary to be protective. Now, everybody knows there's two doses, and this is the ugly variant, the 1351. How good are these vaccines against 1351? Well, here's what you're going to hear, that the 1351 is more than twice as resistant as the wild type virus. And that's true. Other studies show it's 50% more resistant. So it is more resistant to the vaccine. But we're getting a level in the thousands. For the wild type virus that we first identified in the United States a year ago, you need a level of 10. For the South African variant, you need a level of about 18. And the virus is producing a level in the thousands. So you can see how happy we are with the mRNA vaccines. And one other concept about the mRNA vaccine, they are easy to manipulate to cover variants. And so the variant vaccine trials have already started. So you can build a vaccine now that's targeted against wild type and the 1351 variant. So that's where we're going with these. Now, the next one that came down and now is authorized it for use in the United States is the Janssen vaccine, or the Johnson & Johnson. It has a couple of advantages. One of the strongest advantages, one dose works. Well, that's really huge for some populations. Because if you have individuals, and we have a large population of homeless, or a large population of medically indigent, or a large population of individuals who don't show for dose number 2, this vaccine was designed to fit them. One dose works. I can't say that it prevents disease in 70%, but it prevents serious disease in 70%. That is, those who get the vaccine are much less likely of getting serious disease. Now, it looks bad compared to these numbers, and perhaps it is. All I can say is it's not as good as these numbers, but this is still a great number. This is far better than the flu shots that we take every year. This is really good stuff. And for the variant, it's a little bit less effective, but it is being used in South Africa now because it's got about a 60% chance of reducing severe disease. Now, these are the 3 vaccines that are available in the United States. I get calls very frequently, well, which one should I take? And the answer is take whatever you can. Just because you take one vaccine now doesn't mean you can't get another one a year from now. Don't hold out until you get one vaccine that you really like. Take whatever you can get. To stop this epidemic, we need people vaccinated. And so take whatever you can get. The question then that follows of this about the vaccine, well, if I take the vaccine, can I get an infection and give it to others and not even know it? And I'll tell you the answer is no for the first 2, no for Pfizer and Moderna. Those studies, preliminary results are out. If you have a good vaccine response to Pfizer or Moderna and you get exposed to the virus, it will be swallowed and digested in stomach acid. It will not establish an infection. Therefore, and I'll say this at the end, currently our present thinking is that it prevents shredding. So that's the current thoughts as of today. Unknown yet for Johnson & Johnson vaccine, but there's reason to think it will follow the same pattern. This one is of concern. I'm not sure where we're going to go with this vaccine. As a scientist, we have to evaluate things not based on allegiance to a company, not based on anything except the results. And right now, Oxford AstraZeneca is having a difficult time coming up to par. And that's why I put this as dose dependent. They're really looking at the vaccine to see if we change the dosing, can we get a better response? So just because they started off with a particular dose doesn't mean that's the best dose. And so that's what's going on right now with Oxford AstraZeneca. They claim they're going to have enough information to present to the FDA next month, but I think it will be scrutinized much more closely than the other vaccines because of the difficulties that have been reported around the world. This is being widely used in Europe. It is not being used at all in South Africa, and it likely will be available certainly within the next few months. I shouldn't say available. It will likely be presented to the FDA within the next few months. But it's the next one on the line, and Novavax is coming not far behind it. But of all of these, Johnson & Johnson is the only one that is approved for one dose. Now, what is going on with the J&J vaccine is, yes, it's out there, it's great, it's fantastic, but what if you give 2 doses? If you get a dose a month after the first one, can you take this 70% and kick it up to the 95%? That's what's being looked at today. So that's kind of a quick overview of what's out there. And the next questions are the common ones. What about me? I've been vaccinated. Do I need to worry? Do I have any concern? Do I have to wear a mask? Do I have to do social distancing? And this is now being addressed. So this is where we are. After the vaccine, can I spread the disease? Well, not with Pfizer, Moderna, possibly with the J&J, and almost probable with AstraZeneca. Are boosters coming? Absolutely. But will you need it depends upon variant. If we see no variant strain in the United States that is resistant to the vaccines that we have, then you won't need a booster, at least until the vaccine wears off. If we see a variant that is resistant to the vaccines that we are giving, then yes, a booster will have to be built to cover the variant. Vaccine passport. I'm going to talk about that a little bit. Right now it's a question mark. And what this means is, will I have to show proof of having had a vaccine? Or more importantly, if I have proof, can I do certain things that otherwise I could not? And we'll talk about that. After the vaccine, still recommending masking and distancing. And I'll tell you, it's from getting our fingers burned. It's from saying that you don't need to wear masks than having to say masks work. We're just a little bit cautious, so we're not expecting a change in masking and distancing, even for those who have been vaccinated. So right now the answer is yes, meaning no change. You should continue it. This may not involve many on this call, but recommended testing is done a lot of places where I work. So it's done on hospital employees. It's done on nursing homes. It's done in my laboratory employees. Regular routine testing. And this is now a maybe. I think we're going to slide into a no, that if you have been effectively vaccinated, you can be excused from weekly testing or biweekly testing. This is the statement that came out last week. And I will tell you, I was on the call when this came out. I was happy it came out. I see problems with it coming out, but it's what the public wanted to hear. So if you have been fully vaccinated is defined as 2 weeks after the recommended regimen. So 2 weeks after one dose of Johnson & Johnson, or 2 weeks after your second dose of Pfizer or Moderna, you can visit with other fully vaccinated people indoors like old times. So if you've got neighbors, family, friends who have been fully vaccinated, then they can come over to your house, or you can meet with them in a restaurant indoors. Remember, indoors was the dangerous place. You can do this without wearing a mask. Big statement, very risky for the CDC to come out with it, but they did. The next one, if you have been fully vaccinated, you can visit unvaccinated people from a single household who are at low risk. So if you are an adult and you are fully vaccinated, you can meet with your grandchildren, with your kids if they are in the low risk group without wearing a mask, because you're not going to be spreading the virus. And if they have the virus, you are likely protected. So that's a big statement. Now, this is really what I think is the nuts and bolts of the reopening, that those who are fully vaccinated can visit with unvaccinated people indoors, but not at a big party, not at a gathering of 50 people. This intentionally is starting off slow to see how it goes. The old saying, baby steps first. So unvaccinated people from a single household. And then most people know this, but the quarantine is that if I am exposed to someone who has a known case of COVID, I have to quarantine myself for 10 days. Well, if I have been fully vaccinated, that is no longer necessary. So even if I will tell everyone on here, I am a frontline provider. Yes, I am fully vaccinated. If I am exposed without protection, without mask, without distancing to someone who has COVID, for example, maybe a neighbor of mine, I do not need to quarantine. So big changes for those who have been vaccinated. And this is what may happen. I'm expecting this to occur. I think we will see a vaccine passport that defines certain things that we can do. On the left is Europe. No, on the left is Iceland, I think. And on the right is Israel. Israel has already implemented this. Iceland has this. This is an international certificate of vaccination. It is a 2D barcode that can be scanned. And if it's scanned, it better match your driver's license and your date of birth, or your federal ID, because it means you stole the phone from somebody. But that's this. Iceland is issuing this. Where it's being used is to be determined. Israel is issuing this, and it is being used. They have already started this. You need to show this to go into certain restaurants. So in the country of Israel, if you've been fully vaccinated, you will get a vaccine passport. And there are several retail places, and most restaurants now are permitted to say, no, I need to see if you've been vaccinated. You cannot enter here if you have not. This has been deemed ethical and legal because it's for public health protection. We already do this for yellow fever. There's countries that you cannot get into without a yellow fever certificate. I think we may see something like this for airline travel, for TSA, perhaps even for certain things in the United States. I don't think it's going to be a government requirement. It is more likely to be a retail or consumer requirement. There's some things about the government requiring it that are very, very touchy from a legal perspective, and the lawyers don't want to go there. but we may see restaurants in our area say, you have to show permission, proof of vaccine to come in. So my last slide is kind of a happy slide, and then I'll close it off, and then we have about 10 minutes left. Some things we've learned. One of the things we've learned, because we've gotten burned, is we preface everything with currently, but this may change. So if I told you that this was a respiratory virus today, I should have said currently, but this may change. We think this is a respiratory virus. And with something that is moving this quickly, we're learning the value of that. Since this is a group of leaders, I can say we've gotten burned many times in science. Prepare for what you can't imagine. How in the heck can you interpret that sentence? Prepare for what you can't imagine. If you can't imagine it, you can't prepare for it, but we have to. So we have stockpiles of things that we can't imagine ever having to be used. Things that we did not have going into this pandemic. We have plans, procedures, protocol, disaster plans. Can't even imagine needing them, but we have to be prepared. And if we don't use them for exactly what we have designed them for, maybe they will apply to something else that we can't imagine. Mixed messages has been a catastrophe during this year. Mixed messages from teachers like myself, mixed messages from media, mixed messages from the politicians, and all they do is create mistrust and confusion. My biggest advice to anybody in a leadership position is do everything possible to avoid mixed messages. No one knows how to deal with that. And I hope that I haven't given you any mixed messages today. This last one is something we've learned, but I don't know how to fix it. So uncoordinated implementation of guidelines. And what I mean by this is in the United States or around the United States or under the auspices of the United States, we have 64 state and territorial and tribal governments. Each of them has the legal ability to establish and implement guidelines. And no one knows it better than us in California. Our governor has passed legislative restrictions that differ from those passed by other governors, that differ from those passed by other governors. Even something as simple as who gets the vaccine, but something even much more important as who can go into a restaurant. And the fact that we have this uncoordinated implementation of guidelines and legislation has created chaos in the United States. It is to be avoided if at all possible. Now, because of our infrastructure, I don't know if it can be avoided. I'm not a political scientist. If we have another situation that comes up, another set of guidelines, or even the guidelines I showed you earlier about what you can do after the vaccine, we actually live in a system where I told you that you can meet with other fully vaccinated people without wearing a mask. But in California, our governor can disagree with that and say that's not permitted. And governors in other states can disagree with those other things. So this is a difficulty that creates an ongoing problem. Guidelines as critical as this in something that is a public health emergency really benefit if they can be coordinated and uniformly implemented. And lastly, never ever have a pandemic in an election year. That was our biggest mistake. Oh my God, we just never should have scheduled the release of this virus during an election year in the United States. It has created problems that all of us have seen. Many of us have suffered. I have people calling me names because of what has come out during this election year. It became whoever thought a virus would be a political football? Whoever thought a virus would be so important in a presidential election? So next time we have a pandemic, I'm going to say this. You have my word, we're not going to release it in an election year. And with that, I will stop. Thank you very, very much again for the wonderful invitation. It's always a pleasure to do something like this. And I will leave it open to anything that anyone wants to say.
So Gail Israel has her hand raised. So Gail, why don't you go ahead and ask your question? Dr. Joseph, can you stop your screen share so that we can see each other?
Certainly, I think.
Thank you.
Well, I think I have to get out of this first. And there we are.
Perfect. Thank you. So
Hi, oh, sorry, here I go. Hi, Dr. Joseph. Nice to see you. We seem to travel in the same circles.
I just periodically invade yours, I think.
Well, thank you for the great presentation. I have a question regarding, so you often say we, and I was just wondering if you could clarify, is we doctors who study what you study, we, your affiliation with the CDC? Just thought it might be nice if you clarify who you're speaking for.
Well, I appreciate that. That's something I try not to do. It's a bad habit. It comes from many years of hearing it. So I would have to say that in general, what I'm talking about is CDC and the consensus of scientists who believe in the CDC findings and recommendations.
Great, thank you. That helps.
And well, I appreciate your pointing that out. I think for all of the talks that I give, what one would think that I would know better.
Well, and I didn't mean it as a criticism. I just thought it would be, you know, Rachel gave a great introduction of your background, but I just kind of wanted to, it's helpful when you get the information to know, you know, what you're basing it on. That's
well, I think that's a good point. I would emphasize that there are many camps in science. For this pandemic, one of the biggest camps is the NIH, the CDC, who are aligned, not necessarily with the World Health Organization. Definitely have some differing opinions there. When I say we, I'm in that very conservative NIH, CDC environment. And I don't take it as a criticism. I take it as construction. So thank you.
Bill, why don't you take the next one? You're muted though.
Well, first off, Dr. Joseph, this was a fabulous presentation and it was recorded. So this will be going out to many others who will view it. Great summary. I took some photographs of your slides. Thank you very much. We miss you, not seeing you every month or if not every couple of weeks. My question is, and again, I know you're hesitant to do predictions, so I'm not looking for predictions. I'm just thinking of your judgment. Your thoughts come as late as this coming September. We had this conversation at our leadership meeting this morning. We have classes of about 30 adults meeting once a month for a whole day. And we are thinking, are we going to be able to meet as a group in person by September, 30 adults in a room all day? And if your not predictions, but your judgment on what do you think the landscape may look like for those kinds of meetings in 5 months?
You know, you're so skillful at this. I don't want your prediction, just your judgment.
Well, your judgment, your thoughts about the trends.
But this is not a prediction. This is a judgment. Is that in my judgment? Yes. In the absence of a variant that is resistant to the vaccines, absolutely.
Even groups of over 25.
Yes. Yeah.
Now, I understand you're not making the call for the state and you're not making the call for local. We just want to know your opinion.
Yeah, I think that it is a general feeling that with the popularity of the vaccine, which is different from many vaccines, that we will have reached a stable state. Now, it may require a vaccine passport.
Okay.
That could be one use for a vaccine passport, saying we're having our meeting, but only for those who can prove that they have been fully vaccinated. But for those who have been fully vaccinated, it is my judgment, not my prediction, that it will happen and will be safe.
Good. Thank you, sir.
And the hurdle that was raised in our meeting, that would be the next question, is that our local governments who provide a lot of facility space for such gatherings, they're being comfortable renting it out. So that's another whole piece. And so maybe the vaccine passport could be, the wicket that could make it happen, almost like it's also a waiver that you're not going to hold the hosting facility, liable for anything or something like that. So that's good to know. Bill and I are both on this committee to look at what happens next year with Leadership San Ramon Valley, and we really want it to return to more of a normal program. So that's why we're both kind of focused there. Anne, you had a question. Go ahead.
I do. Dr. Joseph, many, many thanks, because I was a regular on the virtual breakfasts through the city of San Ramon and just learned a lot from you. I'm curious, it's been a year since we've shut down, and what have you learned in terms of how this virus impacts children? Because we've been hearing like mixed reports, or just a lot of questions on how children are impacted by the virus. Do they don't normally get it? I mean, there's just been a lot of different information out there. And so I'm curious what you know.
Well, if it weren't for this rare complication of the post-viral inflammatory syndrome, that is something like Kawasaki's disease, I would say it's a blow-off. Don't worry about it. But it is a recognized risk for kids. So in the absence of a post-viral or post-infectious immune complication, the kids do wonderfully well, just like all of us did when I grew up with measles and mumps and rubella and chickenpox. In the absence of a complication, the overwhelming number of kids do well. I have learned, I'm not a pediatrician nor a psychologist, but I have learned that kids need kids. And if there is, I am shocked at the mental, I don't know if that's the correct word, but perhaps the behavioral changes in kids that have occurred because of the inability to go to school. I'm a student of that, not a professor.
Alan, why don't you go ahead and ask your question? Before you go, though, why don't we leave it that if Dr. Joseph is willing to stay, I'm willing to keep hosting, but if anybody has to go, by all means, just sign off when you need to. Is that okay with you, Dr. Joseph?
I'm good on time, yes.
Okay, so Alan, go ahead, and then after Alan, Gail, you go after that.
Dr. Joseph, until today, I would be hard pressed to find any similarity between lawyers and scientists. In fact, I always said I went to law school because they don't have biology classes. But what I realized is that in the law changes every day. So you can't rely on any certainties. And you kind of alluded to that in the science of COVID, is that it's what's happening today. And I have a feeling that most of the populace is really looking for certainty. And that's the one thing that they can't have with this COVID. And therein lies the communications problem. Because when Bill Clarkson asked you the question, I think you gave him the answer that he was looking for, but it didn't sound like he wanted to accept it right away. It's the challenge, I think, in trying to get a message out, is that that your certainty has got about a 24-hour half-life, but the population doesn't know that.
Well, that's very well stated, and perhaps I should add that to my slide of lessons learned. There does need to be an emphasis that everything we do has a half-life. Everything we do has a time frame. And I say now, Gail, when I say we, I mean all of us here. No matter what is done, there is a time frame. What we do for our kids, what we do for our parents may be correct today, but it may not be correct in a decade. Well, this virus is a 24-hour changing event. Many of the things that I talked about today, I didn't learn until within the past week. So I think one of the lessons learned is to start off by getting that message across, that this is one of the most rapidly changing environments that I have ever been in. And but to me, it's not that surprising. If I were to look up the treatment of heart failure, the first thing I would do would be look up the date of the publication. Well, if the date of the publication was 1960, I know that that's not going to help me. And I think scientists and lawyers perhaps do know that by virtue of years of training and experience. That is a message that is important to get across to everyone.
So I just asked Rachel via chat if I could just give a quick update from County Health. So we had a briefing this morning. And I'm hoping to avoid mixed messages. Now I'm going to be cognizant of that every time I give a report. But I just wanted to pass on some good news. The county is now averaging 8,200 vaccinations a day. And last week or this week, we got our first shipment from the feds for our federally qualified health centers, of which I think we have 11. So that's adding greatly to the stream. And the last thing in regards to that is that the health officer today, in the next 48 hours, is going to be looking at our reservations that we have, our appointments. We've been able to move through the eligibility categories very quickly in the last 2 weeks, and looking at numbers and our allocation for next week, and hope to open up to those 50 to 64. So that's coming soon. So that's just great news. And the county had a goal of 1 million doses by July 4th. And it's looking like we're gonna maybe be able to move that up to Memorial Day. So we're really moving quicker than we had been, and a little quicker than expected. So anyway, that's the good news I wanted to pass on.
Thanks, Gail. Joyce, go ahead, ask your question.
Oh, okay. I wanted to do a little bit of clarification. I have had both my vaccinations, and the second one was more than a month ago. And I haven't seen my grandkids since October of 2019. But I wanted to ask a couple questions about traveling. I'm a road trip person, and I wanted to get a little bit of clarification. If I need to take a one-day drive, say to Southern California, and I'm only going to stop for gas once, then I'm assuming that's pretty safe. But if I want to go up to Washington State and I have to stay one night in a hotel on the way up, in addition to getting gas and eating or fixing my own food in the hotel, what do you think about that? I mean, I'm not about to step on an airplane, but that seems like too big a step. But I'm just really curious what your take on things like that are.
Well, because you are fully vaccinated, you have a tremendous amount of protection. Assuming you are in that 95% of individuals who has a good response. If we remember the first principle that this is a person-to-person disease, then you can guide all of your activities based on that tenet. So very simply, you can get gas 4 times a day, just put on a mask and get gas. Since you don't have to worry about going into a gas station where an attendant is going to help you anymore, you know it's going to be safe. If I were driving to Washington, I probably, even though restaurant indoor dining is permitted in Oregon, I wouldn't do it. But takeout is available everywhere, and I would probably do that. Or outdoor dining, depending upon the weather and the location. And then seeing your grandkids, absolutely.
Thanks.
Mm-hmm.
Dr. Joseph, I have one more question. And it relates to my role as a school board member, because we are looking at how can we get children back in school full time for next school year. And where we are challenged is by being able to accommodate full time with a whole class full of kids at a time and continue with the 6-foot separation. Are there measures or things we could be advocating of the state or decision makers about what we could do to safely mitigate the 6 feet, say to 4 feet or 3 feet, but to do other layering to allow us to do that distance. And they seem to say, oh, we say you can do 4 feet, but convincing our staff members as well as some of our parents that it's safe to do 4 feet is our challenge. So is there a way we could package the other precautions to make them feel more comfortable about that safety?
Yeah, I think so. Not surprisingly, this is a common concern and a question that comes up frequently. A little bit of a gambit that I have suggested has said, diffuse the distance. Don't make it, well, we can't do 6 feet, therefore we can't open. But rather, let's create a safe environment. And distancing is only one component of that safe environment. And the wording is 6 feet if possible. It's not 6 feet, it's 6 feet if possible. Well, we know in our area that the bricks and mortar, that is the size of the physical plant of the school, many times that's not a possibility. The rooms just aren't big enough for the number of kids. Other things that can be done are education, educating the parents and the kids for signs and symptoms of respiratory virus. Testing, if at all possible, that is a face card. And you know what has been done in some places, but not in California, is pooled testing. Now, let me tell you what pooled testing is. Pooled testing is that you collect a swab from 10 kids and you put them all together and you test once. And there are test kits out there that are approved for pooled testing. And if it's negative, all 10 kids are negative. If it's positive, then you have to test each one to find out who's turning that test positive. So testing is another face card. Plexiglass between desks has been discussed at length. Is it reasonable? Is it feasible? Is it financially possible? Increasing air circulation, whether it's by floor fans or ceiling fans. But with kids in general, what you want are fans that blow down, not that suck up. So if somebody is exhaling coronavirus, you want it to hit the floor, not to come up into the air. All of the faculty and all of the administrative staff and all of the adults with whom the kids would come in contact should be vaccinated. So this starts to create a laundry list of things that can be used to diffuse the distance. Masking is a very difficult thing. I think I defer that to teachers and child psychologists and professionals like yourself. We're obviously talking about an age group that can wear a mask, but we may be talking about an age group that really can't wear a mask effectively. But if that's possible or if that's realistic, that too is on that list.
And with that, we're sort of testing that right now with the children that are back in hybrid. So far, the masking seems to be fine. What about the double masking in there? Does that help with the relaxing the distancing?
Well, all of these are theoretic. So it's never been compared masking without distancing or masking plus distancing. The greater the filtration, the better the mask. And the reason for the comment about the double masking is many individuals were using very porous cotton because it's comfortable as heck to put a t-shirt over your face, but it's not a very effective mask. On the other hand, tightly woven cotton is not as comfortable. It gets hot. Well, that's a difficult concept to explain to a general public, but 2 layers is I don't want to say a layperson's, but it's an easy to understand way of increasing the effectiveness of a mask.
Okay.
When I wear a fabric mask, I wear quilter's cotton. And that is extremely tightly woven cotton. There's no reason to wear 2. But if I were wearing a mask that I might purchase at a pharmacy or a hardware store, 2 layers might be more reasonable.
Thank you.
Mhm.
I don't see any other hands. Does anyone else have a question they'd like to just go and ask? Okay, seeing none, let's go ahead and wrap up. I can't thank you enough. What a treat to be privy to, the hot off the press, brand new information. And you, again, never disappoint about how understandable you make it.
Well, thank you for the invitation, and thank each of you for all of the work you do for our community. I feel privileged, and have said this many times, very privileged to live here. So thank you both. I'm going to sign off and answer some of these crazy calls that have been ringing in the background.